Let's see the pitfalls that may happen when we diagnose thrombus in the left ventricle. One of the more common is this aspect we see here, a reverberation from this area. This produces reverberations within internal layers that makes this kind of reverberation with several layers. This kind of reverberation gives a false impression of an apical thrombus. If this wall were contracting normally, you'd know that the possibility of thrombus is minimal. Thrombus of ischemic origin only occurs in walls with abnormal contraction. If this apical wall is akinetic or dyskinetic, and there is something like this in the apex, frequently it may be mistaken as a thrombus. So how can we make the differential diagnosis? First, because we see that the width of the reverberation is about the same as seen in these brighter regions that we see outside of the cardiac image. Look here. These are the brighter regions. They are the layers that will reverberate. Notice now that the width here of the possible thrombus is about the same. Second, because this edge of the possible thrombus is not situated at this location, as this wall, for instance, this edge is being made right in here, close to the transducer, and the image it produces is here, away from the transducer. If this were a structure at the same depth as this wall here, if we angle the transducer to one or other side, this wall would also change its position accordingly. If this were a thrombus, it would be located at the same depth as this wall and would have the same displacement. Then, this distance from the thrombus and the wall would be maintained. For instance, if we move the transducer to this place and this were a thrombus, that distance from the wall would be maintained, since it would be a real structure at same depth. But since this wall here is at the depth, and this reverberation is produced from this depth, here, closer to the transducer, if we change the position of the transducer, this reverberation will have a different displacement compared with this wall. In other words, when we move the transducer, this region here of reverberation will enter inside this wall, since it has an angular displacement different from the wall. This space shortens or widens, depending if we angle the transducer one side or the other. Look this example. This is a reverberation coming from this region here. See, as it has the same width, we would not mistake it as a thrombus, since these walls are contracting normally. But this patient here has an apical wall contraction abnormality, and we see something here that might be a thrombus, since there is a condition for thrombus formation in this wall. It is a thrombus or a reverberation. See how it may be difficult, the differential diagnosis. Now, look at the width of this brighter region outside of the heart in this apical fourth chamber. It's about the same as here of the possible thrombus. Now, at the two-chamber view, the width of the brighter area and also the thrombus decreased equally. Furthermore, it was in the center of the cavity. Another common cause of mistake in this diagnosis is the presence of left ventricular trabeculations. Most of the time they are easier to differentiate since they have a trabecular or filiform aspect and usually don't look like a solid mass. There are always some space behind it with blood. Here it's easy. First, because the walls are contracting well, but also notice that it has several trabecular lines linking one side to the other, indicating it's not a thrombus. Look at these views. There are trabecular lines and with the space behind them, showing this is not a thrombus. Occasionally, it's difficult to differentiate. In this case, with certain contractility problem, in this wall, it may have a thrombus here, but these are trabeculations. Look how there are filiform trabeculae here that even comes to the IV septum and also spaces behind it, but occasionally it's difficult to diagnose if within all this trabeculation may have also a thrombus. This one here is a very typical trabeculation and should never be confused with a thrombus. In different views, you can see that it's a line and behind it there is a space. Then this is a trabeculation.